So please welcome Dr. Graham Swinney.
So, the plan is I'm just going to talk to you briefly at the beginning before we get Stephen on. But just to have a sort of review about SDMA, sort of where we've been and where we are now with it. Looking at reference intervals in different species and different age groups with that. Looking at SDMA in a couple of different disease situations and looking how it fits into the IRIS scheme for looking at kidney disease with that. And we'll also have one case that we run through with that. So we'll start with little Molly. So Molly's a 7-month-old female Shih Tzu who was presented to her primary care veterinarian to be spayed. The owners were very happy with how she'd been doing. She fitted in well to home, she was eating well, seemed to be growing well. When the vet questioned them, they didn't actually volunteer about her urinary changes, but the owner noted when questioned that she would occasionally have urinary accidents in the house. But they'd put that down to the fact that she was a slow learner, and it mainly seemed to happen when she was excited. So the owners weren't actually terribly concerned about that. So her physical exam was unremarkable, so the plan was to do a CBC in chemistry as a pre-anaesthetic screen on her. We'll come back to her in a few minutes. So, we've got a lot of things that we do diagnostically for kidney disease at the moment. I'd have to emphasise here we've got sort of laboratory tests, but a good history and physical examination are still a really important part of what we're going to do for diagnostics with kidney disease. But these tests we've got now are still all very important, but they all have their limitations. You're looking at urine concentrating ability or a complete urinalysis, so physical, chemical and microscopic exam of the urine. You know, the specific gravity is very important and a very inexpensive test that we can do. But, you know, you don't lose concentrating ability until you've lost around about 2/3 of your renal function, and it can also be affected by other diseases or medications which can complicate the interpretation of it. You know, doing a UPC ratio on a urine that's already had a sediment exam to make sure it's not post-renal proteinuria is very important. And some patients with kidney disease will have proteinuria before they lose concentrating ability and before they become azotemic. But not every patient, so we can't rely on that alone. Microalbuminuria is a test that's very sensitive for trying to pick up protein, but has limitations with specificity because lots of other things can make it positive. It would be lovely if we could measure GFR on all of our patients, and Stephen will mention that a little bit more later on, but it's not necessarily practical to be doing in your sort of day-to-day life in practice. When we look at urea and creatinine, they're markers that we've relied on for a number of years, and we're going to still be relying on them for years to come. But, you know, we've got to have lost around about 75% of your renal function before they increase. We can use creatinine better than we do now. If you look at a patient's own history with the creatinine level, if it's increasing even within the reference interval, that should give you a clue to take more of a look at that patient's renal function. But they're both affected by other things. Urea can be affected by, you know, pre-renal disease, can be renal. A high protein diet or gastrointestinal hemorrhage can make it go up. A low protein diet could make it drop a little bit. Liver failure can make it drop. And our big limitation with creatinine is that it's affected by lean body mass. So there are some breeds of dog, for example, like, you know, well, we don't say pit bulls anymore, do we? American Staffies, or a greyhound, you know, may have a creatinine that's above the reference interval just because they're heavily muscled. And I'm sure you've all seen that sort of old cat that comes in that looks like it's got renal failure. Its urea's high, it's not concentrating its urine, it's in really lean condition, and the creatinine is not as elevated as you would expect. So they're still useful markers, but they all have their limitations. So that's where SDMA comes in, so symmetric dimethylarginine. It's a test that's been used in human medicine for a while, more in a sort of research setting, but a few years ago they developed, validated a liquid chromatography mass spectrometry assay at IDEXX to use on dogs and cats, and put it out there to have people work with it to see what they found. And there are 3 significant findings that came from that research. There are over 40 publications on it so far. First is that it's a really nice biomarker for kidney function. It is a really nice marker of glomerular filtration rate. And I think one thing I'll emphasise to you tonight is we have to think of SDMA as a marker of GFR. We know that it goes up earlier than creatinine as renal function deteriorates. And the third thing is that it's more specific for kidney function than creatinine. So, arginine is an essential amino acid that's used in protein metabolism in all cells. In that process of being metabolised, it gets methylated and produces a few different byproducts: monomethylarginine, asymmetric dimethylarginine, and symmetric dimethylarginine. The SDMA pretty much hangs out in the cell until the cell dies. It is sad, but all cells are going to die sometime. And when that cell gets broken down, the SDMA is released into circulation, where it's almost exclusively excreted by glomerular filtration. And so that's why it's a nice marker of GFR. And as we said before, it goes up earlier than creatinine and not impacted by lean body mass. There was some work done out of Hill's Pet Nutrition in the States. This is not a research colony with dogs and cats in little cages. They live a pretty grand lifestyle here, and they've got dogs and cats in lots of different nutritional studies that they're looking at. And some of these animals have developed kidney failure over the time that they're in there. When they looked at the dogs in this group, on average, the SDMA went up 9.8 months earlier than the creatinine did. In cats, it was on average 17 months earlier than the creatinine. So it has the potential to give us indication of loss of renal function much sooner than creatinine. And when they looked at the sort of calculations, it would go up potentially as early as 25% loss of renal function, but reliably when you've lost 40% of your renal function. So compared to the 75% for urea and creatinine, we're looking at a marker that is going to show up a reduced GFR significantly earlier. Also done out of Hill's, they looked at the effect of lean body mass. They have this very fancy device called a DEXA scanner, which is a non-invasive way of looking at lean body mass. And they looked at both cats and dogs to see the effect of loss of lean body mass on the renal biomarkers. Stephen's going to talk about this a bit later in more detail. But this is on the left, a feline study, on the right, canine. And what it showed is that as lean body mass was reducing, the creatinine fell. So, and in some of these animals, their glomerular filtration rate was dropping, but the creatinine fell in line with the lean body mass, whereas the SDMA remained stable. So it's showed in both of these studies that the SDMA is not affected by lean body mass the way creatinine is. So that's going to be important for us. So when it was first developed, work was done to develop reference intervals for dogs and cats. And it just worked out in both the reference interval studies for the different species that the reference interval was up to 14 micrograms per decilitre for both of them. It's also been checked for horses. If any of you happen to see horses and want to check their renal function, SDMA also goes up to 14. What they found, they have the benefit at IDEXX of looking at all these results coming through, sort of looking at that big data. And they were getting the impression that sometimes young dogs had slightly higher SDMA levels. So they did a second reference interval study looking at young animals. And what they found is the majority of puppies are still going to be in the 14 range, but some of them will go up to 16 with that. The question arises sometimes of, well, when does the puppy reference interval become the adult reference interval? And that's going to vary with the puppy. So if you have a small breed dog, probably by the time they're 6 months of age, they're going to be in the adult reference interval. If it's one of those large breed dogs, it might be 12 months or older before they get sort of to being an adult. It's tough being a large breed dog, isn't it? You're sort of a puppy for ages, then you have a short adulthood, and then you're a senior dog much earlier. They looked at cats too, and so they looked at kittens with SDMA. And again, looking at the initial data, they felt that the reference interval was going to be higher, potentially even a little bit higher than it is for puppies. So when they did the reference interval study, they actually looked at the data very critically with that and found that all the kittens that had a higher SDMA had been sedated. A lot of them it was in shelters where blood was being collected sort of pre-anaesthetic, and they were running SDMAs on those. And the kittens that had been sedated with the majotomidine style drugs had significantly higher SDMAs than the kittens that weren't sedated. And so the thought was potentially reduced renal blood flow was causing that, almost a pre-renal cause for that. So non-sedated kittens should be in the 0 to 14 range. Just because they're looking at seeing if the immunoassay that IDEXX developed to run SDMA can be used on people. They've looked at it in laboratory rodents, and so if you want to know that, it's 0 to 11. If we look at the data that we've gotten from our experience in Australia, which is well over 150,000 samples that have been run so far. Now keep in mind this is some well patients, some sick patients, so we're just looking at that data generally. When we look at cats, 14% of the cats that had bloods come in had an elevated creatinine. There was another 21% of them that had a normal creatinine but an increased SDMA. So identifying a significant, greater proportion of cats with a reduced glomerular filtration rate. Keep in mind that could be pre-renal or renal with that. When we look at the dogs, 5% had an elevated creatinine and another 15% had a normal creatinine but an increased SDMA. So potentially identifying as, say, a greater group with reduced GFR. It would be remiss of me if I skipped over this small group, 1% of the cats and 1% of the dogs and 2% of the cats that had an elevated creatinine and a normal SDMA. A few potential explanations for that. On the dog side of the scale, potentially a heavily muscled dog, probably less likely to be the case in cats. It can just be biologic variation. So a lot of those were animals that had an SDMA of 13 or 14 and a creatinine that was just mildly elevated. And if you repeat that in a few weeks, they'll tell you the same message. And the third thing is the immunoassay for SDMA in the lab does not like a lot of hemolysis. So if it's a moderately or markedly hemolyzed sample, it can make the SDMA measure lower than it actually is. So keep in mind this is a lovely new shiny biomarker we've got, but you still, like any other laboratory test, need to interpret it in light of the rest of the results in the patient. So if you have a patient that looks like it's got kidney disease on history and it's not concentrating its urine and it's azotemic, especially if the sample's hemolyzed and the SDMA is normal, believe the patient with that. But it's only a small number of ones that we see that with. When we look at the international data with this, no surprise for cats and both dogs that the incidence of kidney disease increases as they age. But we do see a percentage of young animals that have got potentially a reduced GFR. So, worth keeping in mind that it, can be a test that you do on younger animals as well. Less numbers with dogs, but still a proportion of them there that can have kidney disease or reduced GFR that could be congenital or acquired at that age with that. I think, in the first couple of years, SDMA has sort of been considered as, a test for chronic kidney disease. But given that it's a marker of GFR, it's also important to remember that it can be a marker of acute kidney injury as well. There was a study that was reported out of Europe where they looked at azotemic animals based on clinical history and other laboratory tests. They classified them as acute kidney injury or chronic kidney disease with that. And what they showed in this study was that the SDMA will be elevated with both acute kidney injury and chronic kidney disease. They tried looking at the numbers of, estimated creatinine ratios and all sorts of things. They weren't able to differentiate acute and chronic using the SDMA, but important to remember that it will be a marker of acute disease as well. I'm sure you're all familiar with the IRIS, so the International Renal Interest Society guidelines. So they talk about, diagnosing kidney disease, staging kidney disease, and then guidelines for treatment. They've incorporated SDMA into the diagnostic part of their guidelines. And I think when we think about trying to diagnose stage 1 kidney disease, that's always been a challenge in the past. Potentially a patient with chronically low urine concentration, a patient with proteinuria, but unless you were checking the urine for another reason, you wouldn't necessarily have detected that. a patient whose creatinine was increasing within the reference interval, but unless you're looking at those previous results, you might not know that. Or a patient that's got abnormal renal imaging. So unless you were doing an abdominal ultrasound for another reason, you weren't necessarily going to find that. So it was difficult to try and diagnose stage 1 patients. But now with the advent of SDMA, we have a tool that's going to be much more reliable and much simpler for trying to identify those patients with, potentially stage 1 chronic kidney disease. When we look at the staging scheme, that's still going to be based on creatinine, and substaging with blood pressure and urine protein creatinine ratios. The SDMA may influence the way you manage them. IRIS suggests that if you've got a patient in stage 2 based on creatinine, but they're in lean body condition and their SDMA is persistently above 25, you should probably manage them as if they're a stage 3. If they're stage 3 based on creatinine and they're lean and their SDMA is over 45, we should probably manage them as if they're a stage 4 patient. The question arises then of what do we do if we have a patient with an increased SDMA? Now, clearly, if it's a wildly increased SDMA and they're azotemic and they're not concentrating their urine, that's pretty simple. You're going to treat them as if they've got kidney disease. But we can have patients that will still have some concentrating ability, are not azotemic, but have an increased SDMA. And some of them, that increase in SDMA is going to be mild. And the question is, what do we do in that situation? And what we want to try and do is avoid the two extreme ends of the scale. One end where it's like everything else is normal, so I'll just ignore the SDMA and hope it goes away. Or the other end of the scale is, oh, SDMA is high, they must have chronic kidney disease. Here's a bag of insert the kidney diet you stock in your clinic here, and you send them home with that without doing any more testing. And I think if we identify a patient with an increased SDMA, it's giving us, and they've potentially got stage 1 chronic kidney disease, it's affording us an opportunity to try and see if we can find if there's a cause there for it that we can manage, and then to try and protect their kidneys to see if we can take steps to slow the progression. So, if you've got a very mild increase in SDMA and there's no other markers of kidney disease there, so they've not got clinical signs, their urine is fine, everything else is good. And remember, if you've got a high SDMA, if you haven't collected urine already, they should have a complete urinalysis. So physical properties, chemical properties, and a microscopic exam. But if all of that's normal, no signs and it's 15 to 19, I would probably not do anything at that stage other than get them back in a few weeks to recheck it, to determine is that a persistently increased SDMA. And part of what we need to do in this process is go back to the patient and review their physical exam to make sure they're not dehydrated. It's hard to detect mild dehydration, but SDMA is a marker of GFR, so it can go up with pre-renal disease as well. If the SDMA is more markedly increased, or it's persistently increased, or there are other signs of kidney disease there, we should do some investigation. So do that complete urinalysis, check their blood pressure, do a urine protein creatinine ratio. If you think it's appropriate based on the signs in the urine exam, do a urine culture. If it's a dog that's on a farm or does a lot of bushwalking that you think might be at risk of leptospirosis, I'd check them for that. If it's a cat, maybe check their thyroid function. Go back to the client and see, has there been any recent illness or exposure to nephrotoxins? So there's a lot of things we can do there. Management-wise, if you found something on that investigation, well, let's treat that and see if that improves their renal function. If not, there are some simple things we can do to try and help them. Make sure they've got free access to water all the time. If they're an inside-outside dog or cat, make sure there's water on both sides of the door. If it's a dog that someone likes to take running with them, make sure they take water for the dog as well as them. Simple things like that. Make sure they're on a good quality diet. I'm not going to stand here in front of you today and say, oh, they have to be on a kidney diet straight away, because right at the moment with stage 1 kidney disease, do we know if that's going to make a difference? We're not sure. But there are some patients out there that are eating some remarkably poor quality diets that have a lot of phosphorus in them. Even just putting them on a good quality adult maintenance diet that has a sensible level of phosphorus in it is going to try and help slow progression and good quality protein. You know, if you think their disease is progressing, it maybe affords you the opportunity. We know if they've got, you know, clinically significant kidney disease, a renal diet's going to be helpful. Maybe getting them started on that kidney diet while they're still eating is going to be helpful. We need to be careful about nephrotoxic drugs, and, you know, the one that people always comes to mind in this setting is, you know, that does get used routinely is non-steroidals. And I am not going to stand here in front of you and demonise non-steroidals, because guess what? A lot of these patients are middle-aged or older dogs or cats, lots of whom have degenerative joint disease or something like that as well. And so we don't want to say, oh, I'm sorry, you've got to live crippled and sore because you've got stage 1 kidney disease and we can't give you an appropriate non-steroidal to give you a good quality of life. Guess what? If they need the non-steroidal, they should have it. But, you know, trying to use the lowest dose you can, you know, trying to maybe combining it with another drug so we can use a lower dose with that and monitoring them appropriately. If they're going to have an anaesthetic, make sure they're hydrated, monitor their blood pressure during the procedure, get generous and give them an extra hour or two of fluids, you know, as they're waking up to make sure that they're properly awake before you take them off the fluids. And then obviously for monitoring, if you have a patient that we found something to treat, you'd want to monitor the SDMA to see if it's improved with that treatment. And even if it's a stage 1 patient, potentially we're going to want to monitor them a bit more closely than if it was a patient that everything was normal. You know, kidney disease and thyroid disease can be a bit of a challenge. You know, there is that thing of, you know, how many heavily muscled hypothyroid cats do you see? So they can have a low creatinine because of that. You know, as part of their disease, they might have increased cardiac output. And I feel very nervous talking about this in front of a feline specialist, but, you know, they can have increased cardiac output, increased renal blood flow, and that can sort of artificially bolster their GFR. So it's harder to detect that they've got kidney disease. Am I going to tell you that SDMA means that you will pick up every cat at risk of kidney disease when you treat their thyroid? Goodness me, no. But with a marker that's going to pick up a 40% loss of kidney function as opposed to 75% loss of renal function, you're going to pick up a greater proportion of those at risk. They looked in the States at IDEXX at a subset of cats that had hypothyroidism, and they looked at them, and, you know, as the T4 increased, as their renal function deteriorated, the creatinine went up in 3.5% of the cats, the SDMA went up in 20% of them, so potentially looking at detecting a greater proportion of those cats at risk. Guess what? You still need to treat their thyroid disease, but you're going to, you know, monitor them a bit more closely and look to see if you find that point where they get a little bit more azotemic. As I've emphasised, SDMA is a marker of GFR. So it can increase with post-renal disease as well. So with urethral obstructions, the SDMA can increase in that setting. At the Animal Medical Centre in New York, they do a lot of interventional radiology for things like urethral obstructions and stuff. And what they found there is, yes, the SDMA will go up in that setting. The degree of elevation of SDMA and creatinine before the obstruction is relieved doesn't have a prognostic effect. So even some of those patients with markedly increased SDMAs and creatinines will improve when you clear the obstruction. This paper came out of Hills again, where they were looking at cats with nephroliths. So they had 43 cats with those. Some were diagnosed ante-mortem, some post-mortem with that. And they compared it to some healthy geriatric cats. When they looked back, these were cats that had samples stored back on. When they went back and looked at them, the SDMA was increased in the vast majority of cats with the kidney stones. A much less proportion had the creatinine increased, and the average time the SDMA went up before the creatinine in these cats with renal stones was 27 months. So the question is, when do we use SDMA? Well, clearly, if you've got a patient that you're worried about kidney disease, it's a nice marker to look at. If you're monitoring patients that already have established kidney disease, it can be nice because it's not going to get affected by lean body mass the way creatinine is. But it also has a place in patients that are well, you know, because we're trying to detect stage 1 kidney disease, and those patients may be clinically well. So if you're doing wellness profiles, you know, some people do it sort of through different life stages, or at least if you're doing it on your senior patients, it's worth including SDMA in that to try and see if we can pick up disease sooner, or patients that you're going to be putting on non-steroidals or things like that. It can also be useful in those patients with PUPD. I'm sure you've probably all had patients that they're PUPD, you get a urine sample, they're not concentrating their urine, but there's no apparent cause for the PUPD on the urinalysis, and their blood work is normal, and there's that question lingering in the back of your mind, could this be a patient that's just in that in-between stage where they've lost their concentrating ability and they're not yet azotemic? If you check an SDMA and it's normal, it's pretty unlikely they're in that sort of 66 to 75% range loss of renal function, so it can be helpful in that setting too. If we go back to little Molly that we talked about at the beginning, her CBC and chemistry were unremarkable, but fortunately this was a case where it was a profile that had the SDMA in it. So urea and creatinine were normal, but the SDMA was 20, so mildly increased. That prompted the vet to collect a urine sample from her to look at. The urine was poorly concentrated at 1022. The chemical analysis was unremarkable, but on the microscopic exam, they found a few white cells in there and some bacteria. And this was on a cystocentesis sample, so that carries significance. What they did was submitted urine for a urine culture, started her on some amoxicillin clavulanate, but the owners were concerned, so they organised an abdominal ultrasound to be done. What they found on that, it was a specialist ultrasonographer, that both the kidneys were slightly small, there was renal pelvic dilation, which in a patient that wasn't on fluids, and the fact that she had a urinary tract infection was suggestive of pyelonephritis, and she had slightly thin renal cortices. So the conclusion was she had some degree of renal dysplasia, but had likely pyelonephritis. They cultured an E. coli that was sensitive to the clavulox, and she recovered with that. So what the SDMA did was identify that she was a patient with a reduced GFR that prompted the urine collection, which found the urinary tract infection, which prompted more imaging with her. So it really facilitated appropriate management and provided a higher standard of care with that. So in the next little while, the SDMA is going to be available as a slide on the catalyst with that. It's going to be an immunoassay on the analyzer, so like the T4s or phenobarbs or things like that. So what it's going to be is in the conjugate, there is some anti-SDMA antibody in there. So if there's SDMA in the sample, that antibody will bind to that. In the well of the sample, there's MMA in there, the monomethyl arginine. So any SDMA antibody that hasn't been bound there will attach to this MMA in the well, and it's got a marker on it will cause a colour change. So during the immunoassay, the more colour that develops, the less SDMA there is in the sample. So it's going to provide you in about 10 minutes an SDMA value in-house. They've compared it back to the gold standard liquid chromatography assay. It compares well with that, compares well with the reference laboratory assay. So it's going to have the same dynamic range and the same reference interval on that. And they've done studies, and it compares well to the LCMS assay with that. So just in review, I don't think I've gone too long over. So just to remind you that SDMA is going to be a useful biomarker for you in practice, both in patients that you're suspicious of kidney disease or in wellness studies. The reference interval will vary a little bit with age and also by species. It's useful in acute kidney injury. It has a place in some other disease states. And it's important to remember that it's been endorsed by IRIS, but there is a plan there of what to do. If you have that mildly increased SDMA, there is a plan to follow with that to try and determine the significance with that. So, do you want to hold the questions till the end? Steve? Any questions? Yeah.
You mentioned that creatinine is affected by lean body mass.
Yes.
In which way would it affect?
So because remember, and Stephen's going to talk about this more a little bit later on, but it comes from muscle. So as lean body mass reduces, the creatinine will drop. Yeah.
And you talked about proteinuria, persistent proteinuria. So you have a proteinuria that you've got on your dipstick, you've then checked it in,
Yeah, I think if you have a really severe proteinuria on a single sample, definitely, and a bland sediment, definitely warrant to do a UPC. If you find that you've got mild but persistent proteinuria over 2 or 3 samples over 2 or 3, over a few weeks, that's certainly an indication to be, and with inactive sediment, that's certainly an indication to be doing a UPC ratio, along with things like hypoalbuminemia or, newly diagnosed kidney disease or hypercoagulability or things like that.
Check it in 2 or 3 weeks.
If it's severe on one sample, I would do it straight away. But if you've checked a few samples over a few weeks and that proteinuria is mild but persistent, definitely warrants a UPC ratio. Yeah.
You mentioned hemolysis can cause early SDMA.
Yep.
Is there any sort of artifact that can increase it, or is it purely you go to GFR?
Yeah, it's going to be a marker of GFR, but keep in mind, so things like pre-renal disease can make it go up if they're dehydrated or, extremely low cardiac output or things like that. Thank you. We shall switch over.
Thank you very much. Now,